The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD warriors. Welcome to the next episode of this podcast discussing all aspects of TMD, especially the Urbanek Device and protocol. I am Tony Urbanek. Today we have a special guest, and my guest is Dr. Ed Urbina, who will be discussing he is the primary mover for the discussion today, which is entitled Various Orthotics and TMD. As I have discussed many times, how the device that we developed is used and why it's used and how it's used and why it works so well. I am well aware that there are other orthotics that have been developed over the years, some specifically for the use in TMD and some for other purposes. But Dr. Urbina is now and has been my associate in the practice, which is now exclusively devoted to the non-surgical treatment of TMD. And I thought this would be a really good time to bring him on board and to let him speak about his experience, his knowledge, his training, which has been extensive in occlusal aspects of functional dentistry and the use of orthotics in other areas. So I am going to bring him in. So welcome, Dr. Urbina.
Yeah, it's great to be here.
Glad to have you with us on this episode today, which I have titled Various Orthotics and TMD. So we're going to be talking about various orthotics and its relationship to TMD or anything else you want to talk about.
All right.
Pretty much this episode belongs to you. I may have some questions, but first of all, I would just say that Dr. Urbina has been with the practice now for a little over 2 years, but I'll let him pretty much introduce himself. He has actually done one of the other episodes with me before, but for clarity and completeness, I thought I would ask you to give the viewers a little bit about your history, but mostly emphasize your experience in your training in this particular area, especially when you came into our practice and utilized what you knew before and how that applies to what you know now about TMD. But if you just tell the viewers about yourself and mainly your training and experience.
Sure. I've had the joy of, practicing dentistry for well over 47 years in general dentistry. There was a point in my career where I'll be honest with you, general dentistry was getting rather mundane. And I don't say that to minimize the value or the importance of that service, but there was something more that I felt I needed because there were challenges that I was being faced with as I was encountering restorative situations with my patients. And so it was about that time. I had been teaching at University of California, UCSF, there in the restorative department. And then I went and invested in training at the Pankey Institute in Key Biscayne. And that was a turning point in my practice because it was a particular discipline that really helped me in terms of looking more into the nature of what are the issues related to, in large part, iatrogenic dentistry. What are the challenges that we meet when we encounter patients that have dentistry that's just falling apart. I mean, I've had patients who have come from third world countries that had atrocious dentistry, and yet it was holding up remarkably. And then I've had patients who had some exquisite dentistry. I mean, from precise, you can tell by the nature of work was done, that was just falling apart. And this led me with a lot of questions. The turning point for me was that I had a fair amount of restorative dentistry in my mouth. And I had a draining fistula that developed on tooth number 31. And so I spoke with one of my colleagues about it. He says, yeah, let's just, it had had a root canal previously, we'll just do a retreatment. And so upon closer evaluation, it was discovered that I had a root fracture. The tooth literally cracked right through the isthmus. This should never happen to a dentist. I'd done everything I could to feel as though I practiced good quality dental care. I had a nicely gold crown, placed gold crown and issues, and yet the tooth still got destroyed. This started me on my journey of really addressing that problem. In the midst of that, I had a clicking joint. It was, it didn't interfere with my function. I had no pain. And so, and speaking with other colleagues, yeah, jaws click. And so I went on with that. And so it was through my journey at the Pankey Institute that was just a really revelation to my understanding in terms of the impact of forces that manifest themselves in the joint capsule. And so it was then from the Pankey Institute, I went to study at Dawson with Peter Dawson at Dawson Academy. From that, I was just eating up this material because it was really helping to put some of the pieces of this puzzle in my mind about why tooth number 31 got destroyed in my mouth. And then from there, to the Seattle Institute, which is now called, Spear Education. And so these were all disciplines that were pretty much aligned with the same philosophy in terms of occlusion. And in this process, I got an appreciation for really utilizing splints. And so when we talk about splints, we're talking about two basic types of splints that we see in use. We've got a stabilizing splint, we've got an anterior repositioning splint, but amongst all these, there's some characteristics that a splint should possess. And I say this in light of what the Urbanek splint presents. And, and Tony, Dr. Urbanek, I'll have you kind of respond to that in a few moments, but there's some very unique characteristics, some very important characteristics that we want to see in a splint. It should be non-invasive. It should be reversible. It should be aesthetic. It should be retentive. It should be functional. It should be non-invasive. It should help stabilize the jaw relationships. It should provide some desired occlusal patterns. And then it should help protect against parafunctional activity, joint loading and such. And so that's kind of the uniqueness that excites me about what I see in the Urbanek splint. But before we elaborate further on that, most most individuals that have been familiar with any type of splints are probably most familiar with what is called the stabilizing splint. It's the type of splint that is most recommended when we're talking about a neuromuscular condition. It's often called a supportive splint. It's called the Michigan splint. It's the Ramford splint, a flat plane splint, an auto positioning splint, a night guard, or permissive splint. Essentially, it's a type of splint device that covers all the teeth in that particular arch, and it opposes the teeth with equal balance contact. Some will include a ramp for disclusion in excursive movements and in protrusive movements. But it's considered the splint of choice for neuromuscular issues. Now, it's that design that poses some of the challenges that I see on a day-to-day issue when I'm seeing patients, because the concept, and as Peter Dawson would say, that if you have, and I agree with this, if you have the joint, the bite relationship in a centric relation, and you've eliminated the prematurities, parafunctional, all those prematurities, then you shouldn't theoretically need a splint. But one of the challenges that I see, and I'll be honest with you, colleagues, I come across a lot of iatrogenic dentistry. There isn't a concept of occlusion that is very well understood. And interestingly enough, one of our technicians in our lab who has years of experience in crown and bridge, he owned his own laboratory. He said a common concept among laboratory technicians is design the crown low to grow. So in other words, you design the crown out of contact, which is great for the dentist because now there's minimal contact, and you allow the teeth to migrate into position. I mean, it's a wonder, and I'll be honest with you, the fact that we're able to accomplish the dentistry that we do is that God-given accommodation. If it wasn't for that fact that we had accommodation in very varying degrees with the patient, we would see a host of more issues arising sooner than they do. And nevertheless, they do come up. And one of the challenges that and I, Tony, Dr. Urbanek, I've relayed some of this frustration with you, is that some of the dentistry that we see crossing our office is just outright troubling. And because oftentimes the patient is told by the dentist, the patient reports to the doctor, it just doesn't feel quite right. And the doctor responds, well, give us time, you'll get used to it. It'll adjust. Yeah, it will adjust, but there's a price to pay for that adjustment. And it's the patient that pays that high price for adjustment if they don't have the accommodative processes. And so the stabilizing splint is one where, again, it's intended to take the place of where we have these occlusal prematurities and to provide stabilization of the occlusion to take the burden off the muscles and the neuromuscular system. Now, the other splint design is what is often called the anterior repositioning splint. This is perhaps considered to be the splint of choice for joint damage, or if you have a type of derangement in the joint. In other words, if the disc has been displaced anteriorly, often anteriorly or anterior-medially. And so the concept, and this is where we see a number of these type of cases coming into our office with patients that are in pain, and they've had these various types of splints, appliances, But the anterior repositioning splint in concept is designed to place the head of the condyle into position of where the disc currently is. So in other words, if the disc has been moved, has been postured anteriorly, then the task is to determine where that disc is and then position the mandible generally forward in a forward position so that the condyle is now sitting up into the fossa of the disc. And it's done that way with the purpose of not allowing the condyle to move posteriorly so that it impinges on the retrodiscal tissue. The challenge for me, and I'll be honest with you, in the years I practice, I never found this to work successfully in my hands. In large part, the big question in my mind is, where is the disc?
Mm-hmm.
Where is the disc? And where am I going to position and design the device appropriately to seat the head of the condyle into that disc? And so if you read the literature, you find that at best, you have short-term success with an anterior position splint. And the key to this whole approach to treatment is the fact that you need to know where the disc is. That, and you know, when I look at all these options and I practice them with some limited success, in large part, I think a lot of it had to do with the accommodation of the patient. But the interesting thing is that when we look at the Urbanek splint device, what I've come to appreciate is that it's simple. It's simple. You know, and in essence, what we're wanting to do is really just take the load off the joint. And so you have some concepts, and many of you will come across some of these devices that are often called an anterior deprogramming device or an NTI device. In concept, you know, they are attempting to unload the joint by not allowing posterior occlusion to occur. But there are some shortcomings with the NTI device. It doesn't retain well. It's generally fitted to the upper anterior incisors. Consequently, it's difficult to wear during the night when it's most needful. You know, the forces of occlusion with bruxing are going to be significantly greater nocturnally or during consciousness than they are during the day. And so it's not uncommon for me to have patients come in who have tried wearing it and they couldn't wear it through the night because of the instability of the bite. You will come across variations on devices. You know, we have some of our well-known colleagues like Frank Spear, Hoyce, Tanner, who have variations on that concept on that device to provide anterior occlusal contact with posterior disclusion. But as we reflect back on the qualities here that we look for an ideal splint, I'd like you, Dr. Urbanek, to address those issues as it relates to the Urbanek splint. You know, we talked about the ideal characteristics of a splint in terms of it being comfortable, non-invasive, reversible. It's more aesthetic, it's retentive, it's functional. It should stabilize the jaw relationship. It should provide a desired occlusal pattern. And it should help decrease the parafunctional oral habits. I mean, how does the Urbanek device match up to those criteria that we would like to see as, in quotes, an ideal splint?
Well, Ed, thanks for the question. I guess I need to start, and this has been discussed many times on these episodes, but when my patients told me, the first 12 patients said, I put my finger, my tongue, a pencil eraser between my front teeth, it feels better, I decided I was going to see what happened if you did that, actually separated the back teeth and only the front teeth touch. Then I thought briefly, because I was very, experienced with taking orthognathic, making orthognathic splints and orthognathic surgery, and patients having stuff in their mouth and still being needed to function and talk. So I just gave it a little thought. Well, what kind of device could I design that would be usable, simple, that just separated the back teeth but allowed the patient to function, to use the device 24/7, to speak with the device? Can't chew with something like that in your mouth. And that's the design that I came up with, which is nothing more than, a flat anterior plate with enough other portions of the device that would make it feasible to retain it. And ball clasp was the first thought I had, using ball clasps. Now we've done R&D to figure out we can do away with the ball clasps and make the device virtually, using a little change in the design for just retention. But the overall concept is, where can you, first of all, would the device fit over the lower teeth, the lower arch or the upper arch? Well, I can promise you, with my experience as an oral and maxillofacial surgeon, something that goes over the lower arch, I don't care what it is, soft, hard, partial, complete, it's a mess trying to speak with it in your mouth. You're not going to, it's not going to come across. So, the thought process was, well, it's going to have to be something in the maxilla. I had a lot of experience using devices with cleft palate kids, oral devices, palatal devices, a bilateral cleft, bone, palatal bone, whether unilateral or bilateral. Often I made, just a simple insertion into the palate to hold the segments apart while the bone graft was healing. So I was very familiar with oral devices that were used for cleft palate kids. They could talk with them nicely with the thing in their mouth for, 3 or 4 months while the bone was coalescing. And then it's a matter of, well, what kind of disocclusion mechanism would you use? Well, again, being able to have the experience with, like, surgically entering thousands of temporomandibular joints surgically and seeing the damage within the joint and the disc, as you mentioned, who knows where that disc is? And even surgically, it moves from time to time. You're certainly not going to figure out, where that disc is on an anterior repositioning device. You're just guessing at it. But the point I was trying to make is that what it goes on inside the joint, I knew that it was terribly inflamed. Any temporomandibular joint patient always had terrible inflammation in the joint, documented by the pathology report. I was not concerned about putting any loads on the posterior tissues, because I understood how the tissues respond. The point is, just a flat plane that allowed the mandible to go back to centric relation, because automatically, again, with my surgical experience doing orthognathic surgery, ideally, you want CO to equal CR, and to allow the mandible on its own, the muscles will take it back to the most comfortable centric relation. Now, where that exactly is within the glenoid fossa, and the concept of pushing the mandible back manually to get it to that spot, I think that's full of hot air. I think the mandible itself will bring the condyle back to the most functional, the best centric relation that there is. So, just a flat plane, allow the mandible to go back, and that was the design I chose. And I guess, fortunately, it just really worked well. We know it worked well, and fortunately, those were the criteria I used. So, and I knew little to nothing about other splints. I mean, a maxillofacial surgeon. I mean, I did not study other kinds of splints. But when I gave up doing surgery for temporomandibular joints, and I tried to do the scientific method and study it myself, this is how it turned out. And fortunately it did. And fortunately, the kind of splint that I decided to design works extremely well. Patients can talk in it well. It's comfortable. It's fairly inapparent. Some of them, depending on the classification of occlusion, class 1, class 2, class 3, it changes. But in some cases, you can't even see it. In other cases, it's fairly apparent, but patients still can talk in it reasonably well, not any problem. So that's how it all came to be, and that's why it is very unique, and definitely unique in the description of the purpose and the method and the design of the other splints that you described. And that's why I wanted you to come on this episode with me and describe what it is that you know about alternative splints, your experience with them. I am not out, and I'm sure you're not out to, overly criticize anyone else's work in this area. Although, there's things that work, and a different definition of work. There are things that work and there are things that don't work. And that has been my criteria in my entire career, whatever I do, especially in the profession, my selection of surgery. And that is, does it work? Can you get the product? Can you make it work consistently and predictably?
Mm-hmm.
And I found over time that it was consistent and predictable. And our statistics and our study and the thousands of patients that we've used this device on, it works. And so I don't try to compare it to anybody else's experience. I just know that we see a tremendous number of patients in our practice, and I know you do, Ed. You've been with us here for 2 years now, who come in the office, and I kind of laughed. The first time I saw it, I thought it was humorous. I still think it's humorous. They come in with a little bag, sometimes a paper bag. The last one that came in with, she had a little purse. It was, I don't know, it's kind of a colorful little purse. And she shook the purse, and I knew what was in it when she shook the purse. There was half a dozen other little devices in there from who knows where, starting out with the night guards and to, other things. And I usually don't get deeply into where they come from and who made them and why they made them. A patient certainly has no idea, but and then we have to, when it comes to a patient, we're forced to discuss, well, why is your device different and why do you think it's so much better? It's like, well, you have to be a little cautious there as how you address that to the patient, and I try to be, but it is different. And frankly, it's different because it works. And why does it work? Because it does nothing more, nothing less than unload the temporomandibular joint, allowing the inflammation to go away. And I've said this, I preached this, I've discussed it on these episodes literally dozens and dozens of times to make this point that I just made. So when you have our colleagues in my career over the last period of 50 years, and I've heard about them, and all the doctors that Dr. Urbina named, I have great affinity for them. I'm sure that they've worked very hard in their career to try to figure out how best to serve the patient. But I knew by experience that what was being done wasn't effective. Now we have a device that works, and it works simply. It is too simple. I am amazed that I came across it.
Yeah, and let me interject this, Dr. Urbanek, because that's the beauty of this approach, is it's in its simplicity. Not only have I been excited about how it's impacted our patients, I've been particularly excited about how it's impacted me. because you might recall Dr. Urbanek early on and in coming into the practice and shadowing you, and then serving patients. I was hearing this common response from patients, my tinnitus is going away. Now, I had dealt with ringing of my ear most of my adult life, gone to numerous ENTs, only to have them say, your ears look normal. And in essence, they were telling me, you just got to live with it. There's nothing we know that can be done for it. And so I had, but to hear patients respond that their ringing was going away. And it was on one particular occasion, I spoke with Dr. Urbanek and I said, hey, I need to try one of these things because I have that symptom. And the interesting thing is that after about 3.5 months, the character of the ringing began to change. I had learned to block it out, and unless someone had brought it to my attention, I'd be aware of the presence of that noise. And yet, at about 3.5 months, the character began to change, and that caught my attention because this wasn't something that typically happened with me. And then after about 4 months, I'll tell you, the ringing's gone. The ringing is gone. So it has made a believer out of me in terms of the experience and the simplicity. It's just something I wear religiously and find it very comfortable and rewarding to see how it is also impacting our patients.
Well, that's you surprised me, Ed, when you came in and said my ringing's gone. Not that we haven't done that many, many times before, but it surprised me that happened to you. And I went, oh my God. I think that you've really made a good point. Your points, multiple points. Your experience with other devices has been profound. And I appreciate that you sharing your comments and your knowledge, because that's all I do. I come on these episodes and I share my knowledge, and people can make of it what they want. They can think of it what they want, but I've had knowledge along the way, and I appreciate you sharing your knowledge, because I was not knowledgeable on what the alternative splints were that were available and how they were used, and basically what the whole process was and the theory was behind what was trying to be done. I learned listening today from you. I think we'll just pretty much leave it at that, unless you'd like to say anything else about your comments about the orthotics, about the splints, or your opinion. This is opinions are good. I like opinions, and and I want to say, and I've said this many times, almost every episode I say I would really like comments. We know we can justify and give the not only the statistics, but we have the facts of what we do here. And we don't or want to get in any kind of arguments about opinions or experience. But if you have other experiences, if you want to make comments, I encourage comments. I encourage criticism, because we may learn something that we don't know. I'm always open for that, but that's the whole point. That's why I do these episodes, to demystify TMD. And certainly other devices were used and have been used in my entire career, going all the way back when I entered dental school in 1969. And I heard about splints, and at that time it was well known, but way back then, that nothing really worked. And you could make all the splints you want, and nothing really worked. And 40 some years later, I entered this arena and found a solution. It surprises me to this very day. Ed, do you have anything else you'd like to add?
The last things I would say is just, the opportunity for colleagues to experience the rewards that are patients can realize through being relieved from these type of symptoms. And that our task as a community in educating our fellow colleagues, once you get a better sense of the anatomy and physiology of the joint, these principles just make sense. A lot of it is just, practical logic. And us taking the responsibility of being physicians of the masticatory system, and not just simply mechanics of the mouth, tooth mechanics of the mouth. And so I welcome the opportunity to see us move forward in gaining a better understanding of not just how to do things, but why they work. And so I invite my fellow colleagues to, take that challenge to educate yourselves. Come on with TMJ services. We'd be happy to share in the experiences that we are sharing with our fellow colleagues.
Well, I appreciate that commercial. Once in a while I put in a commercial of my own. We want our colleagues to do well, and we have solved the TMD problem. And I invite anyone out there who would like to join our network of doctors to join us. You know how to get a hold of us. I can be reached at Tony@tmjservices.net, my director of education and marketing at Naomi@tmjservices.net. Ed can be reached at, I believe,
Dr. Urbina@tmjservices.net.
Yep. So contact us, talk to us, criticize us if you want. It's okay with me. But I think that's enough for today. I really appreciate you sticking with us. I appreciate your attendance. I look forward to speaking with you again in another week. So for today, this is Tony Urbanek and Dr. Ed Urbina with TMD Demystified.
All right. Thank you.
Thank you, Ed.